Hi everyone, I'm Saleha Singh, and this is Chai Chat and Community, a podcast where we chat openly about what matters to South Asians, no matter which part of the world you live in. Tonight, we are talking about something many families, especially men, don't speak about enough: prostate health. Prostate cancer is one of the most common cancers in men. And here's the thing: when caught early, it's often treatable. But too often, men don't go for checkup until it's a bit too late. As someone whose uncles are in their 70s and their male cousins in their 40s and 50s, I wanted to have a conversation that could help all of us understand this better without fear or shame. So I invited Professor Shomik Sengupta, a urologist, to help us unpack what every man, in fact, every family should know. Thank you so much for joining me, Shomik.
Thank you for having me along.
Before I pepper you with questions, do you want to tell our listeners? And I can see some of them are watching something about yourself, please, Shomik.
Sure. So you've already said I'm a urologist. I am of South Asian extraction, but I've had a fairly checkered history, you could say. So when people ask me where you're from, that classic perennial question, I usually ask, how long have you got? But to keep it brief, I did grow up in India for part of my childhood and migrated here with my family in my mid-teens and have lived in Melbourne for most of the remainder of my life.
And I
And
was also told you were a dux in your school.
now
I
you're going to
got to
bring up
know that on
ancient
Friday.
history. That's all last century and a long time back. But to cut to what I've done, I guess since migrating here is finish school, finish my medical training here in Melbourne, and then done the fairly long process of undertaking surgical training in the field of urology. I spent a couple of years in the US working at the Mayo Clinic, getting some more subspecialized training, particularly in urologic cancer. And since 2006, kind of about this time of year in 2006, came back and started in practice. And I work in private practice, but I also work at Box Hill Hospital in the public hospital. And I'm also attached to Monash University, in which role I do some teaching, but principally it's research supervision. So that's my day-to-day, week-to-week life now.
Thanks, Shomik. So I wanted to mention this, that prostate cancer is the second most common cancer among men worldwide, and it was estimated 26,000 men were affected in 2024, 28% men. And 1 in 6 Australian men is estimated to have been diagnosed with prostate cancer by the age of 85, and the numbers are rising because of lifestyle changes and aging populations. And to make things simple and easy, can you tell us what exactly is prostate cancer and what does it do?
Yeah, so I guess the first thing, people often don't have a good idea what the prostate even is. I get asked
Yep.
very often, what's the prostate?
And where is it in the body?
Yeah, so it is a gland that is part of the male sexual system, but it is located within the urinary system. It sits underneath the bladder at the bottom of the male pelvis. And in fact, the urinary channel, the urethra, runs through the middle of the prostate. So the prostate, its function is in sexual terms. It makes some of the fluid that goes into semen. It has the muscles that expel and bring out the semen during ejaculation. That's its function in life. Some people jokingly say the prostate's function in life is to keep urologists in business. But as men get older, there are lots of problems that can arise as a result of things that go wrong with the prostate. And in very broad terms, there are two groups of things that can go wrong with the prostate. So one thing that affects almost every man is the prostate gradually enlarges as we get older. And just because it's large doesn't mean it's a problem. Some people do confuse prostate enlargement with prostate cancer, but enlargement can have some other effects. It can start to affect how easy it is to pass urine and how well the bladder drains. And then from there, it can not only cause those sort of symptoms and problems that many men do experience as they get older, but then actual medical problems with urinary infections, urinary blockages, pressure on the kidneys and kidney damage, a variety of different issues can arise. So that's one group of things, and they're actually a little bit distinct from prostate cancer, but do cause a wide range of suffering and a fair bit of our work to try and help those men. And interestingly, that also sometimes leads to men coming to us and coming to our attention and then finding prostate cancer. And so it wasn't really the cancer that was originally bringing them to us, but other problems did, and then the prostate cancer was found. And of course, you've already alluded a little bit about prostate cancer. It is a very common cancer. It gets increasingly more common as men get older. So it's pretty rare when men are in their 30s and 40s, but starts to emerge in the 50s and becomes more and more common in the 60s, 70s, and 80s. The other thing that's a little bit tricky about prostate cancer is that it comes in a wide variety of seriousness. So on the one hand, there are those cancers that cause problems by spreading from the prostate to other parts of the body and can even become lethal and kill men. However, not every prostate cancer kills men. So it's a real contrast to some other cancers like lung cancer. Most people who get lung cancer, it's a very serious problem, and many are lethal. One often looks at a ratio between how many arise and how many cause death. And that ratio is very high for a cancer like lung cancer, which is also one of the common cancers. Whereas that ratio is somewhat low. It's only about 1 in 5 of prostate cancer cases that might actually become fatal. And some prostate cancers are actually not going to cause any problems over 10, 20, 30 years. And particularly for an older man or someone with other health problems, those cancers are not something we want to find or treat, because the treatment is sometimes worse than the condition. So that's the dilemma. It's finding the right cancers, finding them early enough to do something about them so that they don't get to that lethal stage or life-threatening stage, but not to find the so-called insignificant cancers, the ones that are not going to cause any problems.
Thank you, Shomik. So how common is it among South Asian men?
So I'm not off the top of my head completely aware of all the statistics, particularly, I guess, in India. India is a big country. Comparatively, the actual incidence and rates of prostate cancer are relatively low. It still comes in, I think, somewhere in the top 10 in terms of numbers, just because India is such a vast country. What I can tell you in broad brushstrokes is that there is a great deal of ethnic variation in prostate cancer. And broadly speaking, people of African heritage, African Americans, people in the West Indies, and even in parts of Africa have quite a high rate of serious prostate cancer. And then Caucasians are next, and Caucasian countries such as US and Australia particularly have quite high rates of prostate cancer. And Asia broadly, and very, very much East Asia, have a lower risk than the average. And South Asia falls somewhere in between. So being Asian, there is a lower risk. Now, that is actually a bit complex, because in some parts of the world, particularly in parts of Asia, the reason prostate cancer is not high in incidence is just because it's not tested for very often. There are often competing other issues that are bigger health problems, infectious diseases, malnutrition, etc. So, and it is a disease of aging. And so in parts of the world, if life expectancy is not that high, that also becomes part of the issue. But in addition to that, there are certainly some degree of genetic variability between ethnic groups. There's also lifestyle factors. And again, you've already alluded to that a little bit. That there are protective lifestyle factors, and it is well known that the Asian diet or a traditional diet, the Mediterranean diet, these are quite protective. On the other hand, westernized diet and a more processed diet and reduced exercise, which I guess we all are increasingly heading in that direction.
Leading sedentary lifestyle.
These things are risk factors, and it is an interesting fact that particularly Asian men who move from Asia and live in a Western country often get an increased risk. Perhaps not all the way approaching the Caucasian men, but certainly an increased risk compared to when they lived in their country of origin.
So Shomik, like I told you earlier, this is something that's very close to my heart, because My dad was diagnosed 20 years ago, and he lived for another 20, to see his granddaughters grow up. So when the surgery was done, and I think my dad was very fortunate, it got caught in or diagnosed early at early stages. But he was asked to change his diet drastically, like get off red meat. And my dad loved red meat, so get off red meat, only white meat, lots of fish, lots of vegetables. And he did. He changed. I mean, he was always very physically active. um, and I see my father-in-law, I mean, at 91 he's very active, and touch wood, never been sick in his life. So does that, I mean, does diet have a role to play? You just said processed meat, processed food among the Caucasian population.
Yeah. Again, that's a complex story, because on the one hand, the greatest risk factor is actually probably earlier on in life, not at the point when the cancer has been diagnosed. We do understand that prostate cancer takes many years, sometimes even decades, to develop, and the real risks for prostate cancer are probably sown relatively early in life, the best we understand, and that's the case with some other things as well. And therefore, to try and address the risk factors at the time when diagnosis has been made, it doesn't help a lot. I mean, already the cancer has occurred. And
Yeah.
many of my patients ask me that: what should I eat? What should I not eat? How should I live? And there have been some studies and some efforts to see whether, if we can change diet, change lifestyle, how much of an impact that actually has on the prostate cancer treatments. Somewhat disappointingly, there hasn't been a huge benefit, and people have been put
Oh.
on various supplements. For example, vitamin E and selenium were felt to be particularly important, and they were tried, and the clinical trial, unfortunately, did not end up showing the expected benefit. Showed the contrary. Having said that, what I normally say to my patients, and I do believe that this is grounded in fact, is that it does not hurt to live a healthier life.
Yeah.
Many men who have prostate cancer and are treated for prostate cancer end up not dying from prostate cancer. We firstly either successfully cure it, or even when we don't, we can make it a longer term, so-called a chronic disease. And the competing issues, such as diabetes and blood pressure and heart disease, are still big health problems. And very interestingly, anything that's healthy for you in one way, it's typically healthy for you in other ways. And I've heard Mark Moyad, who's a US nutritionist, talk about this very eloquently, and say that what's heart healthy is prostate healthy. So generally speaking, all of the advice that I give, that we should give, is related to all of that: reduce fat, reduce processed food, reduce the proportion of animal protein in your diet, eat more fresh stuff, eat more fiber, exercise more, manage stress, all of those things. And that will probably help to the extent that it can, maybe not always in a measurable way regarding the cancer, but it will certainly help your body's resilience to managing the cancer, not to mention its general health status.
Thanks, Shomi. So what exactly are the warning signs? And what, I mean, I know what my dad went through, because Ma was telling me, all the issues that he had high fever, and then blood in the urine, and then, getting up many times at night to urinate, and during the day. But are they the typical symptoms? Is there something else?
So again, one of the things about prostate cancer is that it can cause many of those symptoms: blood in the urine, difficulty passing urinate. But by the time it's getting to that, it's often rather late in the piece. And going back, let's say 30 or 40 years ago, they were the only way that prostate cancer came to light, and often came to light rather late in the piece, and we had limited treatment options by that stage. Now we more often rely on a blood test, and the blood test is called PSA, stands for prostate specific antigen. And it's an interesting blood test in that it is our best test to try and find prostate cancer early. However, although it is prostate specific, it's not prostate cancer specific. So it is sometimes high for reasons other than prostate cancer. Most commonly prostate enlargement, but it can be affected by things like infection, by general illness, by stress, by bike riding. Many men in that age range where we are trying to find prostate cancer are avid bike riders. You would see on Melbourne streets and parks on Saturdays and Sundays in particular. They're called mammals, middle-aged men in lycra, riding around. And they're not normal people like you and I who would go for a 20-minute bike ride. They might ride for 5 hours around the bay. And
I have a couple of colleagues who do that every day.
The prostate, and that's what causes the PSA to go up. So we have to tell them, and sometimes we're chasing red herrings for those men because their PSA is up and we're worrying about cancer. Yeah. And then when you ask them the question, then you discover that they ride a lot, and you've got to tell them to give the riding a rest and then do the blood test, and then it comes back to a more normal level. But I digress. The most common way we find early prostate cancer now is using the PSA test.
And it's free in Australia, isn't it?
It is, well, it is subsidized by Medicare, and depending on where you do it, etc. So, and Medicare always has certain rules. So Medicare will provide a PSA test for men to have just healthcare testing once every 2 years for the average male, and once every year for any male who has a family history, because a family history does increase your risk. And men at a certain age are advised to go and get a PSA test, or at least talk to their GP about getting a PSA test. The age is 50 onwards for, again, average men, and from the age of 40 or from the age of 45 for those men who have a family history, depending on the extent of the family history, whether it's just one person in the family or multiple people in the family. So summarizing things, I think that test exists. It's easy enough to do. You have to just go to your GP, talk about it. One of the difficulties with PSA testing is that because it's not prostate cancer specific, and once you do the test, and if it is abnormal, it will need some action. It will lead to further testing, which may or may not always be pleasant. Most importantly, further testing can turn up some of those prostate cancers which we don't want to find and treat, and then that means that if you have the treatment, that can actually cause more trouble or more harm than the good of treating the cancer. So there is some degree of controversy of whether it should be done, or who should have it, when they should have it. And the resulting issue is that both men, and particularly GPs, are somewhat confused about what should be done and what shouldn't be done. It is not a population-wide screening program, unlike the bowel cancer testing or mammograms for breast cancer, but it is available, and men, if they want to find out about their risk about prostate cancer, should talk to their GP and should have the opportunity to have it done. But one of the great difficulties is that sometimes there is no discussion. Some GPs will just do it. Some GPs will just not do it. And compounding that whole problem is the fact that we all know that men don't always engage with their healthcare or their health prevention, or illness prevention, I should say, and don't go to GPs to even talk about it. So for something that is a simple thing to do, there's quite a lot of complexity behind it in actually getting men to have it done. And that's one of the issues we face that you alluded to in your introduction.
Wow. So, Shomik, I read there is another test called the DRE. Is it complementary to the PSA, or is it a separate test? And
so the DRE is an examination. It stands for digital rectal examination, and I guess the word digital has acquired a lot of connotations since this term was originally coined. It does not put urologists at the cutting edge of technology. Digital stands for the digit, and I guess
as in one, as in
digit as in finger.
Oh, okay.
And it will get a bit graphic from here on in. You can't have a urologist on.
I know that. Yeah. No, I
not expect some of the uncomfortable. I guess I've already talked about ejaculation, so the caveat and the warning comes a little late. And
well, there are many people watching.
Anyone who's having
they're all listening to
having dinner. So the way we feel the prostate is by inserting the digit through the back passage, through the anus, and the prostate sits, as I've told you, at the bottom of the pelvis, below the bladder, and in front of the rectum. So we can feel it. And it is one of the important things to do to feel how big it is, how soft or hard it is, and a hard, lumpy, nodular prostate is something that is worrying for cancer. Now, back in the day when it was purely on the basis of symptoms and often at a relatively late stage that we would find prostate cancer, this was really the main way that we picked up prostate cancer. Thankfully now, the PSA helps us in picking up the vast majority, and PSA will detect cancer in probably 98, 99. It's probably approaching 100% because it's being done more and more. There still remains that small percentage. When I was training and studying, we used to talk about 5 to 10%. I think the number now is down to that sort of 1 or 2%, where the PSA can be normal. And this is the problem with any medical test, and it's a particular controversy when it comes to PSA, that you can have a normal PSA and have prostate cancer, and you can have a high PSA and not have prostate cancer. That's the nature of medical tests. None of them are 100%. But in some, you will feel something that's abnormal, but not see any changes in the PSA. And hence, it's important to have the DRE or rectal examination as an adjunct to the PSA. Now, of course, if men are worried about going to a doctor and talking to them and worried about having a blood test, you can imagine the impact that the idea of a finger up the bum gives them. And that has been a major turnoff for men to
really
actually go and have the checkup. And I can tell you that
homophobia at its best. Oh my God!
Well, I mean, it's discomfort. It is exactly. It is kind of a threat to their self, whatever it might be. And in my experience, at least, one of the and there is data and statistics on this. One of the biggest predictors of men seeking healthcare, and one of the things that brings men to us to get tests for prostate cancer, is a female member in their family. It's often a wife or a partner. And I can tell you that when I do the dreaded digital rectal examination, the female partner often laughs fairly unsympathetically and says, "Look, we've put up with worst thing happening to us for a lot of our life. It's your turn now." But one thing that's happened is it's got de-escalated a little bit. It used to be that an annual blood test and an annual DRE. I think it's generally seen now that it doesn't need to be done that often. I certainly don't do it on men every time they come to see me, but it does need to be done at the beginning. And if something's changing, if the PSA is going up, we need to do it. And if we don't do it at the beginning, then we miss that 1 or 2% that can come about without a high PSA.
Wow. Okay.
You can see why men don't come to us.
Yes. We've talked about, I want to talk about treatment now, hope and support. So if found early, if detected early, what are the treatment options? And can men live full, healthy lives after prostate cancer? My father did, but again, my father, we have a question. So let me just show it to you. Thanks for watching. So Sir, she's watching from Delhi. So is it true that one can die with PC? What is the not of Sir?
PC, prostate cancer, I imagine. Yeah. We I'm not sure if she might have a medical background. We use a abbreviation PC or CAP. CA abbreviates cancer. So prostate cancer, it is a little bit of an aphorism that men die with their cancer rather than dying of their cancer. I think that is.
You're right. That's what she says.
One part of the story, and it goes back to what I was saying before, that many prostate cancers are not necessarily lethal, but it still remains the case that 1 in 5 are. And so, apropos of those stats that you quoted before, that I think those are 2024 numbers.
Yep.
More than 25,000, 26,000 something cancers are diagnosed in Australia per year, and deaths are of the order of 5,000 per year.
Wow.
So it still remains the commonest cause of cancer death in men. So it still is potentially lethal cancer. What that statement particularly applies to is that we increasingly find what's called low risk or insignificant cancer in older men. So if you're talking about an 85 or 90-year-old and there is one of those very low risk cancers, they're not likely to die of that cancer. In fact, they're not likely to ever have any trouble with that. And so that little
So will
statement,
they live with it?
so they can live with it. So to now go back to, I guess, this is a very nice segue into what the question you asked about treatment.
Yeah.
So when we talk about prostate cancer, we often divide it up into early or localized prostate cancer, which is what urologists like myself deal with, and advanced prostate cancer or metastatic prostate cancer, which is principally dealt with by oncologists, and chemotherapy forms the mainstay of many cancer treatments. But in the case of prostate cancer, a bit like breast cancer, there is a much greater focus on hormonal therapy, but there are also chemotherapy and other treatment options there. I'll just mention that about advanced prostate cancer is not really my core expertise. So I'll talk more about localized or early prostate cancer. And those are very effectively treated when we diagnose them early, and when they need treatment. And that when they need treatment is a very crucial caveat. So we are increasingly better at kind of focusing our whole diagnostic steps. So we go through the process of assessing the man, seeing whether they're a bike rider and their PSA is high for that reason, or is there a real concern about their PSA. We then go through, we don't go on just one PSA. We look at 2 or 3 in a row so we can see what's happening over time. Is it a rising PSA? Is it a true PSA? Then typically in Australia, at least, they get an MRI scan, which tells us what the prostate looks like. And if the prostate looks normal and there are no other risk factors, sometimes we won't even biopsy, because the biopsy is a greater risk of picking up the insignificant cancer, and we don't want to do that. So with all of this set of selection steps, if you like, by the time we come to biopsying a man, we're already enriching. We are trying to pick the ones where the biopsy is going to benefit and find us something that is a real threat, is a real cancer that's going to cause trouble, and therefore needs to be found early and would be treated if we did find it. And these days we probably find somewhere between 50 and 70% of men who have a biopsy have that sort of a cancer. So we're really picking up the real cancers that need treatment. And they can be treated with surgery, which again, that's my core expertise, so that's what we do, removing the prostate and some of its surrounding tissues. They can also be treated with radiation therapy, and we work fairly closely typically with radiation oncology colleagues, and they can do radiation in a variety of different ways. They can do external radiation. There is this process of internal radiation that's called brachytherapy, and both are good treatments for prostate cancer.
And
surgery and radiation have
painful?
Say it again, sorry?
Is it painful? The second one that you
all of these treatments are painful in their own way. They all have side effects, which is one of I jokingly say to my patients, we haven't yet discovered the treatment that has 100% success or 0% side effects. The day I do, I can retire and make my millions. But we have effective treatments. Both the treatments, radiation and surgery, broadly speaking, are very high in their curability of prostate cancer. Both do have some side effects. The side effects do differ and vary. The surgery is a big one, so it has some significant impacts in terms of the anesthetic and the surgery. We typically will reserve the surgery for the younger patients, and this is a point that often creates a little bit of mirth when I'm talking to, say, a 65-year-old man, and I say, well, you're a young patient, and therefore I would suggest that surgery is a good option for you. And they say, you're calling me young.
So 65 is young?
So when it comes to prostate cancer, yes, I would classify anyone in their 50s, early 60s as being young. And we talk about the older patients being into their 70s, mid-70s, 80. And at that end of the spectrum, typically speaking, surgery starts to add an extra layer of risk that outweighs its benefits. And then radiation comes into play as a more preferred option. Vice versa, we often do have some concerns about giving radiation to younger men because there are some longer-term impacts of radiation that tends to magnify over time. So obviously a 75-year-old potentially has somewhat lesser period of life expectancy ahead of them compared to a fit and healthy 60-year-old. So therefore the arguments and the discussion becomes a bit different. Having said all of that, at the end of the day, the treatments are somewhat different. Some men might say, look, you're never coming near me with a knife. And others are like, can't you take it out? Isn't that the best option for me? So it's a case of what the patient wants as well, taken in the context of their overall health status and age and so on.
So You mean consent, because consent is a big thing here, isn't it?
Consent, consent comes at the point where they're about to have the treatment, but even prior to
Yeah,
consent, there is this process we call shared decision making. And again, to talk a bit about the options in prostate cancer, it is an area where, semi-jokingly, I say to men that the good news is you've got a few options, but the bad news is you've got a few options, because it is literally like trying to pick which TV I buy or
yeah.
which car I buy. In that there are different features, and there are some things that are better and some things might be worse, and you've got to weigh up all of that information and come to a decision what might be your best choice. Our job is to try and guide you and give
Of
you the
course.
information, but it's a man who's going to live with the go through the treatment and then live with the consequences. So they have to feel that it's the right option for them, and that's where I think the information is really key. And we have to give them that information. There's an increasing awareness that we all have our biases. If I, as a surgeon, am talking to the patients about the treatment options, naturally there'll be a bit of a bias to surgery, and we try to make sure they have the opportunity at least to go and talk to a radiation specialist. These days, Prostate Cancer Foundation of Australia have put in place prostate cancer support nurses, and they play a very vital role in that they're effectively the patient's sort of neutral resource, the person they can go to get information, or say, well, look, the surgeon's saying this, the radiation specialist is saying this. Hopefully, we're saying the same thing if we're playing from the same page. But sometimes they just need some independent guidance, and sometimes they need someone to help them navigate the fairly complex process of acquiring and assessing the information, and then actually going through the various steps in the treatment process, which isn't always easy.
So I'm going to ask you something here. So, you know how South Asian men will not go for checkups. It's as simple as that. Um,
I think it's broader than South Asian men. It's men generally. I think
men
it's a general
generally,
phenomenon,
okay.
and it's compounded a bit by our ethnic outlook
Of
on.
course, cultural beliefs and everything else
Totally.
hand in hand. So, when you talk about nurses who are basically their support system, would it be a male? Would you have male nurses who men can go to? Because maybe they'd feel more comfortable, or is it always a female nurse? I'm thinking of the groups I'm going to share in, and
Yeah. There's,
so
as is naturally the case with some of these sort of gendered professions, there is a preponderance of female nurses, but I know of at least 2 or 3 male prostate support nurses that work in Melbourne or in a regional Victoria. Excellent nurses and excellent support people. Sometimes there won't necessarily be a choice because if they're particularly going through a hospital and being treated there, it is whichever nurse is attached to that hospital. Having said that, it's interesting, that there are, again, this is not specifically South Asian, but when it comes to urological advice or even the digital examination, some men have a preference that they go to a female. Perhaps they feel they're gentler, perhaps they feel less embarrassed.
I'm sorry, I'm laughing. I find it so hilarious.
Yeah, so it's interesting that sometimes the actual outcomes are a bit contrary to what we might expect. But you're right. I think there is that reticence to just go to a health professional full stop. Sometimes it's compounded by an embarrassment factor. One of the other things that exists as a very nice support system is kind of patient support groups. So where there are patients who have gone through the journey, and PCFA runs these groups often in sort of geographic locations, and men can ring up and join in. And some of my men come back and say, until I went to that group and found out there were another 100 men who'd been through it and heard their stories, you feel like you're alone. You feel like you're trying to navigate a fairly difficult path without realizing that other people have been down that path before. So that helps a lot. And once men start talking about it, then they say, I didn't realize. And I've found out 5 of my friends at the golf club have had treatment for prostate cancer. And it's because men don't typically talk about it spontaneously. So they need a impetus or a way to actually raise the issue. And that's what these support groups often help to do.
Okay. Thank you, Shomik. There's a question for you.
Yeah, so the question says, like the annual CA125 for women, is there any blood test? So that's a PSA test that we were talking about, so prostate-specific antigen. And yes, that test is the best test we currently have for trying to undertake early detection. But in fact, that test plays a very important role subsequently in our monitoring of prostate cancer. So some prostate cancers, like I said, that don't have an immediate threat, we might actually monitor rather than treat. And we will do that by doing regular testing of the PSA. And after treatment, we expect the PSA to be reduced in appropriate amount. After surgery, typically it should be 0 because the prostate and its cancer are all removed and gone. And after radiation, typically it doesn't go to 0, but very often goes to a very low level. And then if it remains at that 0 or low level as appropriate for the treatment, then we're happy. And we say, look, your cancer looks like it's under control having had the treatment. And if it does come back again from 0 or it increases from the low level, that's when we have concern about it. And so certainly PSA plays a very important role. PSA tests find prostate cancer and help us to monitor prostate cancer.
And PSA tests can be done in India, even small towns?
Look, PSA tests I think are very widely available.
Okay.
Now, the Indian case, I'm not completely across in terms of the length and breadth of it, but it would certainly be very, very easily available. I certainly know and am frequently sent PSA tests by friends or family to comment on. So certainly anywhere where there are pathology laboratories, it'll typically be pretty accessible. I think there will inevitably be some more isolated regional areas where it will be trickier or harder to access, but not impossible. They'd probably have to travel somewhere where there is a pathology laboratory. And to be honest, I mean, in India, there is probably a level of isolation or perhaps some impoverishment that restricts people's access. In Australia, we deal with a different problem, which is the tyranny of distance. We have people who, even in a first world developed country with probably one of the best healthcare systems in the world, who are just so far away from doctors and from pathology that they have difficulty with access to. So access is a problem some places, but it's a simple blood test, no different to doing a hemoglobin count or a kidney function test. One of the crucial things is it is quite a specialized blood test, I guess, in that it's not just included in standard testing, and that's where that conversation with the GP or the check to see, is my prostate getting checked? Because some men, it's like, I've been having blood tests every year, doc. What do you mean I haven't had a prostate check? But they don't realize that it's not just a blood test; it is the blood test that they need to have for it.
Thank you. Last couple of questions. So if you could say one thing to every father, brother, or son listening, in my case, my uncles, I hope, what would it be? And what can all the listeners listening tonight, what can they do today to protect their health?
So the one thing I would say, which I say to everyone that I interact with, my patients, my family and friends, is to think about and look after your health. And you know, we're talking about prostate cancer and prostate checks, but it applies equally to getting your sugar checked, to getting your blood pressure checked, because these are equally widespread problems. And if you don't go to your doctor, don't get the checkups, you're sticking your head in the sand, a bit like the proverbial ostrich. And I think it is important. It is important to engage with healthcare, go to your GP on a regular basis and ask, what are the things I should get checked? And prostate should be amongst the list of things that do get checked. So that's what every man should have in their approach. We're all guilty. I'll put my hand up that we sort of think we'll do it someday, or we'll think it won't happen to us. And we don't always necessarily go to the doctor and follow up on things. And it's just taking a little bit more of a proactive ownership of our own healthcare. And I think extending that out, it applies to everyone, is that just living a bit healthier day to day, we can all do a little bit better, and taking those steps that we know are the things that help us in terms of preventive health are crucial to do. And if we talk about it, then people will hopefully find it a bit more normal and a bit more acceptable to do.
Thank you, Shomik. Thank you all for watching us tonight. And if this episode helped you understand even one thing better, share it with a man that you care about. Sometimes a simple conversation can save a life. Go talk to your dad, your brother, your husband, and ask, when was the last time you had a checkup? Let's normalize these questions. Let's protect our families. Thank you so much for joining me tonight, Shomik. It was an absolute pleasure. Thank you.